Yeah, thank you so much, Tim, and good morning, everybody. As Tim said, I'm going to give a very brief update on where we are with COVID-19 and then talk a little bit about the business of healthcare in the United States. As always, these slides are facilitated by data collection and analytics from MCW's Institute for Health and Equity. Our analyst there is Ali Namadi. If we can go to the next slide, please. Okay, I want to give you a caveat here. The numbers are up, but they're probably up more than the actual case counts because there's been a delay in reporting cases through DHS. So I want to make sure that people don't overreact to the unfavorable trends that we're seeing here. So our 7-day average is 621. We had a very significant number of cases reported last Thursday and Friday and over the weekend that seemed to be a significant jump over what we were seeing before. Those seem to be coming down now, but in aggregate, they still appear to be trending up, inching upward a little bit. Our positivity rate's going up, so that is an indicator that the case counts are also probably going up. And the R is over 1. Again, that 1.5 number is probably exaggerated based on the delayed reporting that gave us a bolus of cases that actually happened a week or two ago that were reported over the last 5 to 6 days. Looking down to Milwaukee, similar trends. Our average, excluding 2 days of very high reporting, would be just a little bit under 100. That's still a significant increase, but again, inching up and not surging upward. Same with the 4.1% positivity rate. And again, the R is probably over 1, but I think the 1.8 is exaggerated by the delayed reporting. I also just want to talk about a couple of other trends here. The wastewater levels of COVID-19 expressed as 1 million copies per person per day have been trending up. They did not bump up when these cases bumped up to the same level. But we went from about 2 million per day here in southeastern Wisconsin up to about 8 million over the last month or so. So again, there is a slight upward trend that we need to pay attention to. Hospitalizations are stable to trending favorably. We're at the low point that we've been since last May. We're down to less than 25 people in intensive care units in Wisconsin with COVID, and about 150 people with COVID-19 in all of Wisconsin that are hospitalized right now. Deaths are stable. They were trending downward. They're at about 10 per day. And again, it's a trend that we need to monitor as we see cases start to inch upward. But all in all, we're in a holding pattern. One thing I want to point out is even though we trended very favorably for a long time, it bears notice that we have, as a state, have never been better than high levels of COVID-19 community transmission. So even though your individual risk might be low, especially if you're vaccinated and are wearing masks when you're in crowds, we still have a high rate of community transmission. So that would be over 100 cases per 100,000 people over the last 2 weeks. Now, if you look at the county map for last week, and these numbers will be updated tomorrow, about half the counties had medium transmission and the other half had high. But what we did see was most of the counties were stable, but there was a handful going upward. So again, just worth monitoring what's going to happen over the next week or two. The next slide, please. So I'd like to pivot to the business of healthcare in the United States. And if we can go to the next slide, just make some high-level observations. The US healthcare system is the most expensive in the world, and our health outcomes, although they're good, lag other developed countries. And that's a fact that we can't explain away. People tend to say that we have a less healthy population, that we have a more diverse population than many of our peer developed countries, and that is true, but it probably can't account for all of the difference in our outcomes. And we spent 19% of our GDP on healthcare in 2020. Part of that was increased spending from COVID and that our GDP went down by 2%. So as a proportion, we went up from the mid 17% up to 19, but still, that's a lot. And the closest country to us was Switzerland at 12%. As I mentioned, that should say 2020. The US GDP declined by 2% in 2020, and healthcare spending went up due to COVID-19. Yet we're still hovering at about 19% of the GDP. One thing that is different about the US compared to other peer countries is that we actually spend significantly less per capita on public health and prevention measures than other countries. We, as a ratio, we invest a lot more in health care than we do in public health. Next slide, please. Just here's a plot of developed countries showing that as the GDP increases, going from the left to the right, the per capita spending on healthcare increases. And it's almost a linear plot with one outlier. That green dot there is the United States, where we have very significantly higher spending per capita on healthcare, and we're off this very clear line compared to our peers. Next slide, please. And you can see here again, per capita dollar expenditures, United States in green there, at almost 12,000 per person per year, 80% higher than Switzerland, which is our highest spending peer, and double the average of developed countries. So this really, I think, should give us pause and should cause our country to re-examine our priorities as to where we're investing our healthcare dollars. Next slide, please. Our healthcare system is complicated. You see that we've got the providers, predominantly physician-driven here in the US, the hospitals and health systems, the payers and the insurers. And what may be different about us compared to other developed countries is that we've got this big employer box. Employer-funded health insurance is relatively unique to the United States, at least in terms of its scale and scope. And in the middle of all this, we have patients who are becoming more and more consumer-oriented. So that's not that different than most places, other than the fact that we probably have more private payers and more employer-based payment schemes for healthcare than many peer countries. Next slide. Now, this is where it gets very complicated and fragmented. All of these individuals either bill or pay or receive services, these boxes, and I only put a small slice of the different entities that are here. And one of the problems is we have poor vertical and horizontal integration of all these components of the payment system for healthcare in the United States. And you can see that this is very complicated in terms of the providers, very complicated in terms of health systems, laboratories, pharmacies, rehabilitation, nursing homes, diagnostics. The payers actually are quite fragmented. You have three major government payers: Medicare, Medicaid, and TRICARE. You have private payers, you have exchanges, brokers, narrow network products, third-party administrators that take care of the slice of the business. And then employers are starting to come together, either as employer alliances or by partnering with third-party aggregators, where they use their strength and their leverage to try to get favorable deals with the providers and with insurance companies. Next slide, please. So as I said, the US healthcare is the most expensive in the world, but our outcomes lag other countries. I hope that you can see that our system is fragmented, it's complicated, it has bloat for sure, and there's a poor connection between public health and healthcare infrastructure in the US, and that was very, very quickly highlighted during COVID-19. The silver lining is that the COVID-19 pandemic did force new and better connections to be made amongst healthcare providers and the public health infrastructure of the country, but we actually have a long way to go. And as I mentioned, the US spends less per capita on public health and prevention than peer countries do. And I'll show you that on the next slide. I'm sorry, maybe one more slide after that, but yeah, you can see here, this is the ratio of health and social care spending in developed countries. And just a few there, you can see that France, Germany, and the United Kingdom spend a lot more on prevention and social care than the US or Canada. Canada's the nearest peer to us, where they have relatively equal investments in social care and healthcare. But we're the only country that spends less on social care than healthcare. So we're kind of letting people get sick and taking care of things on the back end instead of the front end. Chris, can we go back one slide? I did want to just talk about a couple of issues with the US healthcare system. As I mentioned, there are legal barriers to having vertical and horizontal integration. We have strict regulation that is meant to really to prevent antitrust issues, but these actually get in the way sometimes. And fee for service is still the coin of the realm, so to speak, in many markets. And so you get rewarded for doing more tests, having more patients, and doing more things to them. And there are many, many different fee schedules that complicate issues and add to the administrative burden. There are inadequate rewards in the payment system for the patient experience, efficiency, and quality. Again, it's a per-click mentality. And there's an enormous burden of documentation for our providers. And I want to make sure everyone knows doctors, nurses, pharmacists, physical therapists, the whole array of people working on the front lines are incredibly burdened by having to put their hands on a keyboard and their eyes on a computer screen rather than having their hands laid on a patient or their eyes making contact with the people that they're supposed to serve. This is a dissatisfier. It adds enormously to the burden of work for the providers, and it adds to the cost of our healthcare here. And I don't think that it materially diminishes fraud, but people may disagree with me, but the cost of these documentation burdens is enormous. And the increase, one of the things that's peculiar about the economy of healthcare in the US is that as you get bigger, you would expect that scale would help you lower cost. That hasn't happened yet in the US. Mega regional systems, large national healthcare providers have not meaningfully reduced the unit cost of their healthcare. The next slide, please. Right, next slide. So health is about more than healthcare. I want to talk about the social determinants of health and what other countries invest in that we don't. You can see here, healthcare is an important component of overall health, but it's a small component. Behavior, genes, and social determinants are very, very important, and we need to focus more on those. Next slide, please. Next slide. So what are social determinants of health? Healthcare access and quality. Not everybody is able to have easy transportation or job flexibility to go get healthcare. Education is important. Having high quality education contributes to your overall quality of health, independent of your access to healthcare. The social and community context matters. Economic stability matters. So people living in homes where they can transmit generational wealth to their kids is important. And many people in our society don't benefit from that. And having safe and stable neighborhoods and homes that are conducive to learning, having access to food, all these things are critically important to the quality of health. And because we don't invest in those, we end up paying on the back end in poor quality of healthcare and higher cost of healthcare. Next slide, please. And with that, I want to say thank you and turn it back over to Tim.
Dr. Raymond, thank you. A couple questions, and one that kind of popped in my mind too. In your analysis of the cost per citizen between the US and Switzerland, is the assessment that we use more healthcare or that healthcare here is more expensive to deliver for the same services? Yeah,
it's a little bit of both, Tim. And the third equation is we probably have people in general who are sicker here. We have a higher burden of obesity and chronic disease that contributes to those healthcare costs.
Good. And you did talk a little bit about social care. What would that be, and how could it be expanded, in your opinion?
Yeah, well, that's really the tough issue here. Getting people affordable homes and living wage jobs is really, really important, and that those are not traditional roles for health systems or insurance companies, although some are actually investing in those activities. Having kids that grow up in a family that is economically secure and doesn't live in rental properties and get evicted constantly, like we see, unfortunately, with a lot of the kids in Central City, Milwaukee. They don't have stable homes. Those are some areas of opportunity for us, but I would say having a better public health infrastructure, focusing on prevention, rewarding providers and health systems for keeping people out of the hospital, dealing with obesity and diabetes and hypertension. So our payment model also needs to change to incentivize those behaviors.
You know, as you look ahead and kind of tying back into the front part of the presentation here today on the talent shortages, as Susan was going through that list, I'm sure you saw and heard the number of openings in the healthcare field. So as you look ahead, what kind of an impact do you see the hiring and staffing crisis having on both the quality and cost of healthcare as we look forward in the region?
Well, the cost is going to go up. That, like other industries, the wages have gone up tremendously just over the last 2 years, in part because of COVID. Yet our income is fixed. We have contracts with private payers and the government that don't go up just because your costs go up. So that's going to put enormous strain on the financial viability of our health system, especially critical access hospitals out in rural and underserved urban areas that already are financially distressed. They're going to suffer.
Yeah, and you know, this is a great topic, and one we should probably circle back on, because I know we start this webinar with a discussion of this United Healthcare program that we have. Large employers aside, and I know they have challenges, this is still a very present issue for small and mid-sized employers, often case beyond, in addition to what you're paying in salary and compensation, the healthcare costs are usually second in that line. So again, as you look forward, any thoughts for employers in terms of what they can do?
It's such
and I know, John, you're a large employer yourself, so you've got this challenge also.
Yeah, well, just in terms of our employee benefits, we're trying to incentivize better health behaviors. And that is in some ways a satisfier for people, just that they know that their employer cares and is offering a unique suite of benefits. But I think this is an issue our country needs to grapple with in a much more intentional way than we have. We can't deploy 20% of our GDP for healthcare costs. It's not sustainable.
Yeah.
I do see one question there about normal hospital capacity. Most hospitals in the state run at about 80% capacity. That's the sweet spot for efficiency and not overstressing your staff. We've been running over 90% for 2 years, especially the ICUs. And so we're down back to what would be a normal capacity range for the burden of all diseases, not just COVID. And because as COVID has gone down, that's relieved some of the strain on the system.
Yeah, and then, again, there's a question in here about, and I've seen a lot of the presentations too, going back to the 1980s and 1990s. What do you think is the biggest barrier today to making progress on healthcare costs and quality of care?
A lack of investment in prevention. And you can argue about the social things, but we really don't prevent disease very well here. I think that the fee-for-service mindset here is a problem. I honestly don't believe that there's a lot of cost in defensive medicine, that even though people talk about it a lot, I just really think there's inefficiency in the system that we need to get rid of. I'm not in favor of a single payer system, but I would actually like some harmonization of fee structures for private pay, so that with maybe a market adjustment, so that we don't have hundreds, literally maybe thousands of different arrangements with payers for the same test or the same procedure. It just adds so much to the complexity and cost of care.
Yeah, and I think the other question in the chat you've kind of addressed is there's a shortage of healthcare workers, and you're pulling employees back and forth between institutions. That just adds to the tension. Until we get more people into the field to fill the need, we're going to continue to see that, presumably.
You're right. And we actually in healthcare have seen both a reshuffling and a great resignation. The politicization of healthcare measures, especially ivermectin and hydroxychloroquine, the violence and the extreme rhetoric that's gone on out in society has translated into the inpatient arena, into the emergency rooms. People are they're burnout from overwork and from starting out the pandemic, being called heroes when they didn't really want to be, to being called villains at the end of the pandemic. So there is a great resignation in healthcare. I'm not sure we're going to get those folks back. So as you know, as John was saying, HERA is going to have to work on filling the pipeline back up with new talent.
Maybe Dr. Raymond will finish with the last question here, and then let folks get to lunch. As I look at Philadelphia reinstituting a mask mandate, and then we jump across the world to see what's going on in Shanghai as they're trying to close a city with 25 million people. As you look ahead in the US and elsewhere, what do you see the coming months looking like in terms of COVID and our reaction to it?
We're probably going to have an increase. I mean, we're seeing it already. Whether it'll be a significant bump up like they saw in France and Italy and the UK remains to be seen, but BA2 was driving that, and that variant is here now. I'm hoping, and I think most people believe, absent the emergence of a new game-changing variant in the next few months, that as people move outdoors with the warm weather, we'll probably have lower levels of community transmission. They may still be in the medium to high range, but we won't be overwhelming our health systems. There won't be a lot of people dying from COVID. What we really need to keep an eye on, though, is what happens in the fall when respiratory viruses tend to circulate. And people are tired of mitigation measures. 2 years is a long time to mitigate, and I think that's why China's having a problem. Their zero tolerance policy, even there, it can't work forever. And they didn't do a good job vaccinating people with high quality vaccines. And they didn't have a lot of infections, so they don't have a lot of post-infectious or natural immunity. So their problem is different than ours. You know, we've had a lot of people infected. We've vaccinated a lot of people with high quality vaccines. So I would say that the issue in China for us is more economic than it is pandemic related in terms of infection.
All right, I'm going to squeeze one more in for you. Who should get a second booster and when?
That's a personal choice. Let me just say, if you have been fully vaccinated, you still have very good protection against being hospitalized or dying. Extraordinarily good, 10 to 20-fold better than if you're not vaccinated. But that protection is waning over time, and it's going to continue to wane. So one booster improves, it gives you more time and it gives you more protection. The second booster also, if you're 4 months out from your first booster, will increase your protection. But again, you're starting with a baseline of pretty good protection. So Tim, what I would say is a lot of people are waiting to see what they're going to say to do in the fall. Not everybody wants to get a 5th shot in the fall. But my wife and I decided to get a second booster, and we did that last week.
Okay. Dr. Raymond, again, you're very gracious with your time. I'll see you this afternoon at 4:05 on WTMJ, and we'll have a little chance again to talk about healthcare and the economy. John Swallow, Susan Kane, thank you very much. Enjoy the rest of your day, and thank you for joining us.